Welcome, everyone. I'm Sankara Narayanan. I'm a neonatal consultant at Watford General Hospital, which is a level 2 unit. I'm also the BAPM Executive Committee member for LNUs and SKUs. I'm also one of the chairs of the repatriation framework that we are going to discuss today. Repatriation is a very popular and a daily topic, in the business that we do. I'm really excited to see that there have been close to 200 registrations for this webinar. So welcome again to the webinar. So we're going to be talking about the repatriation framework that was published earlier today. So the title is Safe and Effective Repatriation of Infants. And I'm Sankara Narayanan. I'm one of the chairs for this framework. So just to talk a little bit about this repatriation framework, I'm going to be honest, this is my first chairing experience within BAPM for a framework of practice. And I'm incredibly honored and privileged to do this. And an excellent team of, I had a co-chair, which is very helpful and supportive and very knowledgeable and resourceful multidisciplinary team members who helped us put this repatriation framework together. And we will talk about that today. Just a timeline there about this, the framework. We started recruiting chairs and members in May 2022, and subsequently set up the scope and the terms of reference and started having meetings. We had about 3 or 4 meetings, and the first draft was published in 2023 and went out in consultation in April, finally reviewed and published this morning. I'm really pleased that managed to get the framework done within the time frame given. It was initially it was clueless and it was nerve-wracking, but with support from everybody, we finally got together, and it's a big relief. So this is a slide which shows the framework chair and working group members. I don't have the time to go through every single one of them. I would have if I had the time, but essentially we had representations from medics, nurses, allied health professionals, network representatives, critical care transformation program manager was there. We had data analysts, transport team representation, and more importantly, care coordinators, parents, and you'll also be hearing from one of the parents who had a lived experience of repatriation later. So definition first. So repatriation is, this is a definition from Merriam-Webster in the context of repatriating somebody back to their own home or country. In the context of what we are talking, it's about returning a neonate when ready to an appropriate care location that's closer to home for continuing care. This usually follows a period of neonatal medical or surgical intensive care, and there will be other occasions as well where an infant is receiving care further from home, and we're talking about how to safely and effectively repatriate this baby closer to a care location. So the synonyms used are back transfer and retro transfer, mainly in the American literature. So as we set out writing this framework, the first thing we wanted to look at was what's the evidence out there about repatriation, and we use these search terms to search various databases. Actually, we found that the evidence was quite limited. There's only 8 studies, and most of them were observational and retrospective, and the data set was quite small. But what these studies showed was that in most occasions, the parents wanted their infants closer to home, but they are worried about the unknown in terms of moving from a care location where they are used to the facilities and the care models. They're worried about the unknown. Mostly after the transfer, they had a positive experience, particularly less parental stress. From a baby perspective, infant had better weight gain and breastfeeding. And overall, the cost of care following repatriation was low when compared to receiving care in the higher intensity locations. And also, it's a more efficient way of using the limited resources that we have within the model of perinatal care networks that we provide. Except for one small study that raised concern about there's a higher incidence of retransfers because of infant deterioration following repatriation, but there was a small study. Though the evidence was of low quality because observational and retrospective, it indicated that if done correctly, it's actually a good thing. It results in better family experience. So then we're looking at whether there's any UK data available, and coincidentally, the Hertfordshire and West Essex LMNS, where my unit is, Jackie Dopran, who's a framework group member, who's the Neonatal Critical Care Transformation Program Manager, was doing a repatriation QIP locally, kindly provided this data where she looked at 13 babies less than 27 weeks who were repatriated to 3 level 2 units within the LMNS, randomly selected babies. And we did have a repatriation guideline within the network. She compared the timing of repatriation to already set unit-specific criteria and found that there were 191 care days that were continued to be provided in NICU beyond the 72 hours of infant being ready. And this translated to about 2 weeks roughly per family care further away from home. And as I was doing the framework, you invariably end up doing more work. So we continued with the help of my colleague, Dr. Merchant, who also was an LNU representative on the framework. We further expanded the local Watford data for a 10-month period, January to October 2022. There were 37 babies who were repatriated to our unit, and 10 of them were repatriated within the 72-hour criteria that we are talking about in the framework, in line with already East of England set unit-specific criteria for us. And 27 of those babies, the repatriation was delayed. And then when we looked at that, it's about 347 care days was provided in NICU beyond the 72 hours when the infant was ready to be repatriated. And this, again, sort of similar to Jackie's data, around 2 weeks per family. And the care days were 14 days where the baby was having central line and on non-invasive ventilation with half enteral feeds, which is the criteria for our unit. And the other 230 days were non-invasive ventilation, and 95 were special care days, and 8 were normal care days. We are still working on that data, but preliminary findings shows that most of the delay is related to initiation of repatriation, followed by nursing staffing in the local neonatal unit being a barrier for timely repatriation. So it's clear from this data is that repatriation is could be done better, and you all will be familiar that whenever in network meetings or other forums we talk about repatriation, it's a hot topic where NICU says that we want to transfer, but LNUs and SCUs don't accept. And some LNUs say that NICUs are holding on to their babies, not repatriating them on time, and audience have problems effectively and efficiently managing the patient flow through the network. So we are attempting in this framework to try and provide some structure for that repatriation so that it is done safely and effectively. So the scope of the document is absolutely clinical safety is paramount. We should always operate within nationally set service specifications. And we're considering within the scope of this document, repatriation following medical and surgical intensive care or specialist opinions, for example, ROP treatment or a cardiac assessment. And sometimes unexpected birth happens outside local network, like families go on holidays or visiting family, friends, the baby is delivered prematurely. Or sometimes because of maternal choice, the baby is born outside the network. But this choice only applies to the maternal booking, not necessarily to the neonates. So we've also included that in the scope of this document. What is outside the scope is capacity transfers and more complex conditions and rare disorders receiving care in specialist centers. So the important principles of effective repatriation is clinical safety. Parents should be involved very early in the process. There should be very clear lines of communication and documentation and support. Trauma-informed care should direct repatriation discussions. One of the colleagues will be talking about that in detail in one of the presentations. and it's MDT involvement because the infant will be receiving care from multiple professionals. They all need to be involved in the repatriation process and communicate effectively with the LNUs and SKUs. And there has to be standardization across the regions, networks, and nations as much as possible. And ODNs and LMNS and other organizations and commissioners should provide adequate and regular oversight to this process to ensure effective patient flows within the networks. So trauma-informed care, this will be talked in detail by one of my colleagues, so I'm going to not dwell on that at this point. So within the document, some of you may have read the document that was put on the website this morning. We have a summary of sections, documentation section at the beginning, which essentially talks about the clinical safety. Repatriation should be timely to enhance family experience, and the importance of sharing and signposting the right kind of information to the families very early on in the process, MDT involvement, and there will be some challenging circumstances when the same level of support, usually allied health professional support, may not be available in the receiving unit, and how to manage that situation with different models of care and effective communication and support. And data is really important in monitoring this process. So we'll also will be setting out some metrics within the document for audience to monitor this. And we do have a list of proposed or indicative criteria. And we have a parent story. So straight after my presentation, we have a parent who is going to talk about their lived experience of repatriation from a level 3 to, or from an NICU to a local neonatal unit. There's a repatriation flowchart to simplify all the concepts and points in the document. Thanks to Maggie, one of the trainees who was in the framework group, who put this together, but everybody contributed to the content. So the pathway is the baby receiving care in a service that is away from home. Baby achieves certain criteria. Team checks the clinical suitability of transfer, communicates with the receiving unit at as early as possible. Parents are involved through the process. Several bits of information and resources are given to the family to support them, to make them understand the and accept the repatriation right from the beginning, early in the process. And when local unit is unable to accept, as an escalation mechanism will be built into, and that feedback loop continues. And it goes without saying, parental involvement is absolutely crucial, and that should begin. That should be there right from the beginning and throughout this process. So we have set out some roles and responsibilities for various stakeholders in this process: ODNs, NICUs, LNU SKUs, transport services, and for the regional and national commissioning teams. So talk about the ODN responsibilities. As part of the preparation, when we're looking at the guidelines around in the country, most ODNs do have a repatriation guideline. So they need to make sure that the guideline is up to date, in line, hopefully with the recommendations set out in this document, and to have audits to monitor compliance, develop mechanisms to have parental involvement feedback about repatriation, have some tracking system for in utero transfers, essentially to locate which baby is receiving care further away from home and how can we help that repatriation. And the dashboard should include outside unit-specific criteria care that is provided in NICUs, like HDU, special care, normal care days for out-of-area babies in NICU, and hopefully devise mechanisms to identify from infant readiness to actual repatriation, to present them in their dashboards, and to have a mechanism of escalation and exception reporting when repatriation is delayed, and have adequate information and resources for families on the network websites. And family integrated care passports should also follow the baby through within the units in the network. Likewise, for neonatal unit, they should try and adhere to the network guideline and monitor compliance. Early communication with family, use trauma-informed care approach to support the families, and use already available badge-net tools like patient referral functions to start the communication early with the receiving unit, and work with the ODN in agreeing on and monitoring the escalation pathways. And it'll be useful. Some networks have this and they find it really useful, which is to have a repatriation liaison or link nurse role. And allied health professionals and psychology input, if it is ongoing, how that can be managed in terms of safe and effective handover to the receiving unit. For local neonatal units, again, help work with your network to set your unit-specific criteria, adhere to the guideline and monitor compliance by regular audits, have a tracking system to monitor the outcome of in-utero transfers from your unit, which could facilitate early conversations with the level 3 unit for repatriation. Try and have a mechanism by which you can seek weekly or even more frequent updates from the NICU about the infant's progress. Effective and responsive communication with the parents. By this we mean trying to get the parent over before the baby gets transferred to have them to have a walk around in a unit, or when that's not possible, to have resources like virtual tours of your unit, etc., on the network website or your unit website. And when the repatriation doesn't happen on time, to have an escalation process by which your exception report and explaining the reasons for delay. And the repatriation nurse link role could be continued. And the AHP support, fire care and psychological support, likewise, as I talked about in the NICU document. For transport service, again, agree on the infant stability and repatriation criteria and audit your practice regularly on those criteria. And then agree on a process for organizing repatriations that is easy for teams to navigate and deliver timely transfers. And at a regional level and network level, there should be consideration towards funding a dedicated court bureau that is that functions effectively, and commissioning agreements for neonatal units and transport services to have an accountable and deliverable repatriation pathway. So these are the proposed criteria for LNUs and SKUs set within the document. This is not something that has to be followed to the letter. Individual customization would be necessary. The units, audience should work with the units in setting up these criteria, which will help you to monitor the repatriation process against this criteria. This slide is from the GIRFT report about the gaps in allied health professional input and psychology input into neonatal critical care. And as you can see, within LNUs and SKUs, there is big gaps in allied health professional input and psychology input. So this may act as a barrier because a baby who's receiving this kind of support in an NICU may not be able to receive the same level of support in an LNU. And we had extensive discussions within our framework group meetings and in this consultation process about this. But what we say is that they should not form a substantial barrier to the repatriation process, because there are numerous other benefits of the baby getting closer to home. But if this is a problem in your unit, in your network, it should be recognized and escalated, and should form part of the workforce planning in LNUs and SKUs to optimize availability of these services. In the interim, the level 3 or the NICU-based services should identify ways of supporting the LNU and SKU AHP service, whatever is available. In summary, this should not form a major barrier for repatriation. Within the document, we have lots of resources for units to look at and see what works for them and customize to local use. So data analyst Z has done an excellent appendix around how to effectively use the patient referrals function in Badgernet to highlight an infant at an earlier point and share the infant record with an LNU via Badgernet. There's a repatriation link nurse role and support for families, documents available within the thing. And there's lots of QR codes of good practice that's already happening in lots of places in the country. The resources are, from there. So, for example, there is a repatriation poster, there's a repatriation video that explains the repatriation process in lay terms to a parent, and numerous others. So this would be quite helpful to use these resources to optimize your local process. So in summary, the document is a reference point to drive change in clinical effectiveness. Trauma-informed care and early responsive communication should be part of sort of early process in the repatriation process. Collaborative approach always works and it's an enabler. Parents and families are central to this process. And from what are we saying in terms of the local data, we can say that more can and needs to be done to make this process work more effective. The effective repatriation should be part of national work programs and plans. So thank you. So I'm going to stop here and pass it on to the next speaker. And the question and answer sessions related to this presentation will be at the end of the Q&A session. Okay, let me just unshare first. Okay. So I'm going to pass on to Katy Squires, who is a mother of Jessica, who was born at 27 weeks, and she's a very active toddler now. She's my patient, and Katy and Jessica were in our unit, and we transferred from a level 3 unit. And Katy has very kindly agreed to come and talk to us today about the lived experience, her lived experience of repatriation. So Katy, over to you.
Thank you very much. So I hope you can all hear me okay. So firstly, thank you so much for the opportunity to talk about what is my favourite topic, my daughter Jessica. I'm sure every parent says this, but to us, Jessica truly is a little miracle. On paper, she shouldn't be here, but thanks to the amazing work of the NHS and Jessica's unrelenting pursuit of cuddles, she's here and truly keeping us on our toes. So Jessica came into our lives after many scary complications in pregnancy. At 26 weeks, I was moved and admitted to John Radcliffe in hospital. And at 27 weeks, on World Prematurity Day, Jessica arrived by emergency C-section. She weighed just 865 grams, so I think that's less than a bag of rice. And she just did amazingly well at pushing ahead and growing some very huge feet that she has. She's 15 months corrected age at the moment, and she wears the socks of a 2-year-old. So after 6 days at the level 3 unit in John Radcliffe in Oxford, Jessica was moved to Watford General Hospital, where she spent 10 weeks before finally being discharged home. So today is about repatriation, and I've distilled what are just my experiences and thoughts into 4 key areas. So the first one is our mental state. So I've done a few presentations on Jessica, and I've summarised her story, as you can imagine, to numerous colleagues and friends. Thankfully, it all ended really well. And you tend to gloss over how difficult it really was. When discussing transportation of a premature baby from one hospital to another, it's worth remembering that having a premature baby can be one of the most shocking and emotional experiences of a person's life. It's unexpected. Parents don't know what they are doing at the start, more so than usual. They're exhausted, worried, and upset. our ability to absorb information at the start was really limited. And I'm sorry to say that any leaflets and information packs given to us were really only skim read, because we just couldn't think straight in those initial days. Secondly, on preparation for the move back down to Watford. So Oxford were fantastic at explaining things to us, keeping us informed and asking us what our preferences were. They told us Jessica was now well enough to move to a level 2 unit, that level 3 beds were needed by babies more sick than she was, and they asked us which level 2 unit we'd prefer to go to, Stoke Mandeville or Watford General. They really persevered trying to get us into Stoke Mandeville, because that's where all of my pregnancy appointments had been. But it turned out Watford General was technically our local hospital, so that was where Jessica was destined to go. We felt nervous about the move, but I had met and had really had faith in the doctor travelling by her side, and the transportation team also agreed to my request to travel in the ambulance with Jessica, and that really helped. Moving on to my third point, so the trip itself. The trip itself went really smoothly. It was well planned and the team were very professional. You could tell Jessica was their utmost priority. I was really grateful, as I said, that the team allowed me to travel in the ambulance with her. That meant so much to me. And it reassured my husband as well, who was traveling in the car. I'd had a C-section and the team had explained Jessica was their priority. They couldn't look after me and the trip might be uncomfortable so soon after surgery. I completely respected their honesty and was glad they told me that. I was just glad to be able to watch Jessica in the ambulance all the way. It also meant I could see exactly where the SCABU was at Watford and direct my husband very quickly to the right place straight away. So just moving on to my final few thoughts. So the first night at Watford, the first few weeks, in fact, I'll be honest here, the first few nights after arriving at Watford were very rough for us. The difference between a level 3 and a level 2 hospital was far greater than we'd expected. And including this as part of our preparation, along with what would happen on arrival, could definitely have helped ease that transition. We found it smaller, noisier and brighter than a level 3 hospital. And Jessica underwent numerous tests on arrival, which we understand, but we just hadn't expected, and they upset her. And for such a tiny baby, that was all a little bit upsetting for us as well. We'd had numerous introductions and information provided us, which we were really grateful for. But again, it was all just too much that first night and very draining for us. We didn't end up leaving until something like 10 o'clock at night. And I wonder if transportation could be earlier in the day to allow just that little bit of settling in time for the parents and to make the day a bit more manageable. And just, I guess, summarising, wrapping up, looking back on the decision to move us to Watford, we can really see the rationale behind it. And what matters most out of everything is Jessica's care, of course. Jessica owes her life to those at Watford and Oxford, and we're so thankful for the truly excellent medical care she received throughout. As a result of moving to a hospital closer to home, she was also then surrounded by an excellent aftercare package of doctors, dietitians, and physios in our area who have monitored her since she was discharged and helped her become the real force of nature that she is now. And I'll just share some photos so you can get a sense of just how cheeky she is. So if you can hear me, this was obviously when she was born, really, really tiny. She loved her cuddles. This was her transportation tank, for want of a better word, with her little ear defenders. And this is her as she grew up. she had quite wild hair at the start. And there we have it. I hope that video worked. And I think I'm moving on to the next presenter now, which I think is, was it Davy?
Katy, thank you so much. I know
Thank you.
you're so busy. You know, you've got a very active toddler, and thank you so much. I really appreciate you taking the time today to come and talk to us. I think lived experience of a parent, you know, we can write dreams and dreams of frameworks, but lived experience of a parent is so powerful. So thank you so much.
Thank you.
So thank you. Now we'll move on to the next presenter. Davy Evans is a practitioner psychologist, a framework repatriation framework member. So he's going to talk to us about trauma-informed care in the context of neonatal repatriation. Over to you, Davy. Thank you.
Thanks very much, and yeah, thank you so much for sharing that, Katy. I feel really sad that all of the cameras were turned off, because I imagine you would have had a bank of really grinning faces if my experience of your photos was anything to go by. So yes, thank you very much for joining us for this. My name is Davy Evans. I work as a consultant clinical psychologist for the West Midlands Perinatal Network. I also work clinically on a level 3 neonatal unit in Birmingham. Increasingly, I'm sure you're all aware, neonatal care is delivered by a multidisciplinary team made up not only of doctors and nurses, but also allied health professionals, psychological professionals, and pharmacists. And for me, repatriation is a perfect illustration of the value of this MDT approach, because as we've heard already, it's a topic that elicits very strong feelings from all involved. And it's also a process that has significant implications for the holistic biopsychosocial outcomes for families as well. So I'm going to give you a whistle-stop tour through an introduction to trauma-informed care, a trauma-informed approach in the context of this repatriation framework. So when I talk about a trauma-informed approach, I'm talking about these 4 related assumptions. So firstly, that we realise how our healthcare systems can create, cause and trigger experiences of trauma for service users. Secondly, that we ensure that systems are adequately equipped to recognise trauma when it shows up. Thirdly, that we adequately equip systems to respond to trauma effectively, to minimise the impact of that trauma, and also how we can help systems to set up, to be designed to take a more preventative approach to resist re-traumatizing service users and service providers. So I'm going to take each of these 4 areas in turn and think about repatriation through this trauma-informed lens. So firstly, we must realise the potential for repatriation to be experienced by families as traumatic. So the experience of neonatal care, it's well documented that generally for families this has a significant risk of creating experiences of trauma, and repatriation as an event has a risk of amplifying that experience. It's been described in the qualitative research literature as a critical event, a significant emotional upheaval which increases families' felt experience of threat. If you imagine when an infant is in intensive care or in a high dependency care, families learn to regulate those feelings of threat through the signs of safety in their environment. So things like familiarity with members of staff, close connected relationships with members of staff that are familiar to them, familiar processes and routines and schedules, the familiarity of the environment, and also something that I might describe as outsourced or external vigilance. So that's where perhaps the staffing ratios in an intensive care setting or the technological monitoring in an intensive care setting provides families with a sense of safety. And when an infant is then transferred to a different care location that perhaps provides a lower intensity of care, those signs of safety that families have come to rely upon to regulate their feelings of threat, those change, and sometimes they can be removed. And I think we kind of we heard a little bit in Katy's story about how that change from a level 3 environment to a level 2 environment was a really significant transition for their family. There are some risk factors which might increase the risk that repatriation is experienced by a family as traumatic. So if there are prior experiences of trauma, or perhaps previous difficult experiences in helping relationships, and especially if those have occurred in the hospital or the trust where an infant is being repatriated to, we know that this is often something which can make the repatriation process a lot more difficult for a family to consider. Also, the different makeup of the multidisciplinary team between the unit that an infant is in and the unit that they are going to be repatriated to. You know, the differences in the multidisciplinary team can also lead to feelings of uncertainty as well. So, for example, you know, if we have an infant who has had very intensive input from a team of allied health professionals and perhaps is still struggling to safely establish suck feeds, and then that infant is repatriated to a unit that doesn't have that specialist level of allied health professional provision, that process can feel really unsettling for a family, and that can increase the risk of repatriation feeling traumatic or really upsetting. One of the other factors that can really significantly impact on the experience of repatriation, and it's not necessarily one that we think about directly because it's part of the bigger picture of the neonatal unit, is the context of cot pressures. I'm going to hopefully illustrate what I mean by this with a kind of a brief diagram here. So in a situation where on a level 3 perhaps neonatal unit, and there might be a time where the pressures on cot capacity are low, so there are cots available. There might be cot-dependent deliveries that are planned in delivery suite, but because there are cots available on the neonatal unit, there's no pressure. And what that means is that the team have the headspace to think and practice in line with their values of family integrated care. And what that means is that that team is able to communicate in ways which involve listening to the fears, the worries, of a family around the uncertainty of repatriation, and following their preferences. And what that can result in is the delay of conversations about repatriation, avoiding difficult conversations with families, and so the initiation of the conversation might be delayed. And unfortunately, what that means is that sometimes it can be delayed until actually it's too late, because the consequence of this is that the pressures on cot capacity increase. And when those pressures are greater, the team have less headspace to think. The priority becomes less about family integrated care, more about increasing patient flow through the unit to create more cot capacity. What that shapes is the team's communication. So the communication of the team can switch more towards a kind of command and control style, which means that when repatriation happens, it can happen very suddenly for the experience of a family, and it can happen in ways which might be experienced as disempowering or feeling like it's being done to the family rather than done with them. What that means is the consequence of this, that the receiving team will receive a family and an infant who may be potentially highly distressed, and where professional trust and relationships may have been made more fragile or even potentially ruptured. And what we often see is this kind of oscillating, inconsistent approach to communication around repatriation, which is shaped very much by the context of the pressures on a unit, but shapes communication in a way which really impacts on the experience of families and their experience of repatriation. So the second assumption of trauma-informed approaches is that we recognise when there may be distress or trauma around. I'm not going to speak to this in any great depth, merely to say that when you encounter reluctance in families to engage with the repatriation process, which does happen, it's very unlikely that this is a family who are being awkward or difficult. It's much more likely that this is a family's attempt to regulate feelings of threat and fear. And it's an expression of their fight or flight or freeze response that can look all sorts of different ways. It may show up as tears, it may show up as repeated questions, it may show up as anger or aggressive behaviour, it may show up as withdrawal. And there are lots of ideas within the framework document that's been published today about how you might open up conversations with families about their feelings around repatriation, and the use of very simple questions about how people are feeling, or very simple tools such as distress thermometers, such as the one on the slide here, can really help to open up that conversation. So now we move to thinking about how we can design our systems, our units, and the processes in our units to resist re-traumatization by approaching repatriation in a helpful way. And within the trauma-informed approach, there are 6 principles which help us to do this. So they are these boxes along the bottom of this slide. So promoting felt sense of safety, promoting experiences in relationships of trust, collaboration and empowerment, providing opportunities for facilitated peer support between people who have lived experience of this particular experience, and also a sensitivity to the cultural, historical and gender issues that families bring with them. So just some very kind of practical illustrations of what that might look like. A couple of people have already mentioned this in the webinar this afternoon, the importance of starting the conversation early, right from the very beginning. But actually, we also heard from Katy that sometimes those early conversations, because of the level of distress and the mental state, as Katy described, may make information processing quite difficult. And so it's really also hugely important to keep the conversation going, to keep repatriation on the table, to make sure that the process is not a sudden and unexpected one, but a gradual one. Transitions which involve uncertainty are more easily tolerated when those transitions are gradual, slow and steady. Another important reason for this is that slow and steady approaches to repatriation, which provide plenty of opportunities for conversation between the healthcare teams and families, provide families with opportunities to reauthor the clinical story about their infant. So perhaps when they were transferred to a level 3 unit for intensive care, they started to understand their infant as a very vulnerable, fragile baby. By the point at which repatriation is a possibility, that may no longer be the case. But unless families have had plenty of opportunities to have regular open conversations with the team about their baby's progress, about the care that their babies need, it's really difficult for families to keep that narrative and those stories about their child in line with what their baby actually needs. It's really important that we get to know families at a very early stage so that we can anticipate some of the kind of individual barriers that might show up. This image on the slide here, this framework is available in one of the appendices of the repatriation framework document, and it helps us to really centre our practice in the cultural, historical, gendered needs and presentation of a particular family, and what, you know, asking the question, what matters to this family, what are the challenges that they face, what are the resources, the knowledges and the strengths that they bring, how might that show up in terms of distress throughout these processes, and what will help them. It's also really important that we look at the clinical context as well, to anticipate potential clinical barriers. So going back to the illustrations that I gave earlier, a potentially baby with complex needs that's being cared for by a team of allied health professionals. If we know that this is an infant who's going to be repatriated to a local unit that does not have that specialist level of AHP provision, what does the family and the team need to think about to ensure that this is done in a way that feels safe and collaborative, both for the family but as well as for the team? What plans need to be made at an early stage? And really, and we've heard this already a number of times in this webinar, but, you know, clear and consistent approaches to communication are the key to getting this right. And the message that is helpful not only for families but also for staff members to return to in terms of resolving that kind of strange loop between delaying repatriation and making it happen really suddenly, is that infants require the right care in the right place at the right time. And that is a message which will help us as healthcare professionals to hold on to this clear and consistent message that families really need and benefit from hearing. So then the final kind of little bit of the trauma-informed approach is about how we respond by offering support when repatriation might feel more tricky, more difficult. And this needs to be considered within a kind of stepped care approach. There will be families who require more specialist clinical support and intervention if they are particularly struggling with the idea of repatriation. Most of what I'm going to talk about here is actually more about that universal need, what every family will need when they may feel that repatriation presents them with worries or difficulties. I guess the thing that I really wanted to emphasise is what I've witnessed and observed in many situations around families who express reluctance to engage in repatriation, is that this can often result in conflict. And there's an image here on the slide of a kind of tug of war, and I think that's a really helpful metaphor to hold in mind when you're thinking about how to navigate conversations between healthcare professionals and family members that involve conflict. So if you imagine a rope, for those of you who are struggling to engage with your imagination on a Tuesday afternoon, here's one I prepared earlier. So if you can imagine, this rope represents the different positions that people can take with regard to repatriation, and perhaps on this end we have a position which is that repatriation is really important and it needs to happen soon, and perhaps on this end, this position is that repatriation feels really scary and not something that needs to happen at all. What we often see in these escalating conflict situations is that as the healthcare team advocates more, tries to engage in more convincing or persuading approaches to communication, if you've ever taken part in a tug of war, a real tug of war, you will recognise that as the rope begins to be pulled in that direction, the natural response is to pull back. And this is what happens in escalating patterns of conflict, that people feel unsafe in this this conflictual escalating pattern, and so they will entrench more into their own position. The helpful thing to do in this situation is for the healthcare professionals to understand this position over here and to take the pressure, the tension out of the rope, out of the conflict, and to join the family over here, to ask the questions, to engage in empathic, compassionate communication, to understand what it is about the process of repatriation that feels difficult. That's not to say that you need to abandon your position that repatriation is helpful, but until you join the family over here and understand their position on why this feels like a difficult thing to do, this communication will continue in a escalating pattern of conflict. This is really difficult to do. You know, empathy and compassion are skills which can be learned and trained, and teams really benefit from having space to think and talk about this approach to communication. There's a really great e-learning for health course called Recognising and Managing Conflict Between Children's Families and Healthcare Providers, which has lots of examples actually of conflict in conversations around repatriation. And I would encourage you to have a look at that and share it with your colleagues. And I guess the final kind of things to think about are how we maintain that continuity of support and how we engage in handover and joining up of support between different units. So if there's a family who've engaged with a psychological professional or an allied health professional on a level 3 unit, and then they're into a level 2 unit, how does the team and the family collaboratively hand over that piece of work to the receiving team? And there is some documentation in the appendices of the framework that's been published today that helps you to think about that, and could be adapted if it feels helpful. And I think that's probably where I'm going to leave it. So yes, there you go, a trauma-informed approach. That there's a lot more to say that is not possible to cover in 15 minutes. But if you have any kind of questions, then I guess the framework is a good place to start. But also, I would be very happy to take any questions at the end as well. So yeah, thank you.
Thank you, Davy. That was really informative and thought-provoking. Enjoyed it very much. So now we move on to the next presentation. This is a double act. We've got Louise, who is co-chair for the framework, and Lisa Leppard, who is a framework group member. Both are going to be talking to us about how can ODNs go about implementing the recommendations in the framework. So over to you, Louise and Lisa. Thank you.
Thank you so much, Garrett. So I am going to start, and then I'm going to bring in Lisa. So I'm hoping you can all now see my slide. I've just got the one. So I think what's really important before I talk about anything else really is to talk about what a network is. I've talked here about how networks can implement the recommendations, but we really need to consider that networks are all of you. So not just the network teams themselves, but everyone that works within neonatal services. We really all need to pull together and make sure that we make these recommendations our own and really think about it. And it's been lovely today. I mean, seeing the pictures from Katy really do bring home to you why we're doing these things. So I think the things for me that we really need to think about are something that comes up all the time, data. And as Gara said earlier on, Z did a great job of pulling some resources together in the guideline appendices for you. But I think what I would say to you in terms of making sure this works, think about your data wider in terms of repatriation. So, you know, we mentioned before your workforce. If your workforce is not right, we don't get patient flows, we don't get pathways right, we can't repatriate, we don't get timely babies admitted or admitted within the right unit at the right time. So repatriation is not just that bit at the end, it is the whole process. It's thinking about it throughout it all. And then it is getting your data right. It is making sure that, you know, as network teams, people are looking at this. And for those of you who don't know me, as Sankara said, I was the co-chair on this, but I'm also the director of the Northwest Neonatal Network. So I really do appreciate, both as a nurse in my past and trying to run this from a network and as a network lead, that this is really difficult, that it's not as black and white sometimes as we might seem when we write it down in a framework. But I think really knowing your data and understanding that is really important. I think also having parents at the heart of it and thinking about repatriation as part of your FICare offer, you know, is really something that we need to think about, you know, in every detail of that. And I think Lisa will talk in a little bit about the fantastic work they've done in Thames Valley and Wessex, but I think really think about if you are bringing in FICARE as a network, if you're trying to do that across, how does repatriation work in that whole process? And we have spoken a number of times today about allied health professionals and what's needed. But I would say to you, really think about that carefully in terms of what is needed, what's needed for your particular unit, what's needed for your wider network. And when we talk about what's needed, that's just not about what's needed in terms of your workforce in an individual unit, but how does that translate across a whole network? Because you can have standalone allied health professionals in their own unit, but if we don't communicate well, it does not matter that there's one group in one unit and one group in another, because the messages will still be mixed. The care may still be different. And that is equally really difficult for parents. So it's really thinking about how do we join those two things together, even if you've got people across the system. And then Davy spoke fantastically about trauma-informed care, but as he said at the end, 15 minutes does not do that justice. So I think the other thing to really think about within your units and network is what training do your staff need for trauma-informed care? We'd like to think that everybody would take this approach, that we will do it, but it is not always intuitive. When you are in the middle of a really busy unit, when you are trying to juggle a million things, it sometimes is not intuitive for people to do it. So I think it's really important to think about what training do staff need to do some of these things, to understand some of this approach. And sometimes we say things like trauma-informed care and people just think it's, it's, it's not, that's not for me. I do that already. And I think that's something I would really think about. And think about how that's aligned to everything we're doing. The single delivery plan talks about listening to women and families with compassion and thinking about that. And there's, a real time, I think, in repatriation where that is so important. Transport services, I think, are huge. Noticed a couple of comments in the chat around particular cross-border where you've got, repatriations between different ODNs. I think it's really important to involve the transport service at all levels. So when you are writing guidelines, to make sure that they are part of that guideline, when you are developing pathways, to make sure that those pathways are correct. And as network teams, are your transport teams properly resourced to do this? And if not, where's the business case and who's supporting you with that? And how do we get those things looked at? Because it's really important, I think, that we make sure this is seamless between one unit and another, or as seamless as we can possibly make it. And then I think finally for me, there's something about sharing the learning. So when somebody's done something really well, let's not start again. Let's really use those things, because then we can build an even bigger bank of resources. And that's something, obviously, from a BAPM point of view, that really keen to do. I am the BAPM rep for networks, and what I hope we can do is really build behind this framework some more resources than those that are in that framework for networks to use. We are all really busy. We don't need to do it over and over again. So let's share it. And I think that's where I'm going to bring in Lisa, because Lisa and the team in Thames Valley and Wessex, you will have seen, if you've logged on to any of the resources in the guideline, have done some phenomenal work around repatriation. So I'm going to bring Lisa in now to share some of that stuff, with the very thought of let's make sure that we are sharing some of this great stuff to make as many families as possible have a better experience of repatriation. Thanks, Lisa.
Thanks, Louise. So I'm Lisa Leppard. I'm one of the lead care coordinators for Thames Valley and Wessex Neonatal ODN, and have been leading on the repatriation work stream.
Lisa, we can't hear you very well. Are you able to?
Look at my ears then. Is that better?
Perfect. Sorry to interrupt you.
Yeah, no worries. It's this computer. So I've been leading on the repatriation work stream, which was our first work stream from as part of the NCCR transformation plan to enhance the parent's journey through neonatal care. Louise, are you able to stop sharing so that I can put my slide up? Thank you. Great. Oh, it's gone. Try again. Okay, so I'm trying to try and condense down into about 5 minutes what has taken really and is ongoing work for the last 18 months, the group. So from our initial scoping, when Sarah and I joined as lead care coordinators for all of our units, a recurrent theme came out continually with all of our neonatal units around repatriation. And especially from the LNUs and SKUs in our network, saying that there was inconsistent communication, little or no planning with families, little or no preparation of families in repatriation. And as has been previously alluded to, especially in Davy's talk about the LNUs and SKUs, quite often feeling on the back foot when families arrive with short notice and very little and quite often at times inaccurate information about those units. So in October 2021, we formed our repatriation working group, which was a multidisciplinary team approach, very much having our parent advisory group and parent engagement lead at the fore of that, with AHPs, medical and nursing teams across the whole of the network. And 4 positions emerged from that work, which was better inclusive preparation of parents, better communication between the NICs to LNUs and SKUs, but also LNUs to SKUs, the development of our link nurse role, and renewing and improving the existing framework that Thames Valley and Wessex had, and the development of the communication documentation and the production of the video with We Create, moving closer to home. So very much the early preparation we felt was extremely important. And as has been alluded to, especially in Davy's talk and definitely in Katy's, but actually some of our parents fed back to us that they had no idea what a repatriation was until perhaps the day before or the day of repatriation was mentioned to them. So we sort of really looked at how potentially that we could raise that conversation with parents very early. And actually what we've discussed with our antenatal teams and very much with our midwifery teams who came on board with the repatriation framework was actually about having those conversations with parents antenatally. And I know Katy was saying that there's a lot of information to take on board, but we feel in work with our optimization fellows and our midwifery teams that perhaps part of the optimization discussion with families before being moved to tertiary centres for specialised care is that the aim would always be that they would be coming back closer to home for part of their neonatal journey, and that all of their neonatal journey would not be in a tertiary centre. And that's very much the feedback that we got from families, was that they thought that once they, say, disappeared to Southampton from Salisbury, they would never actually go back to Salisbury again, and all of their baby's stay would be in the tertiary centre. So we're working with our antenatal teams to embed those conversations as part of the peri-prem discussions. I'm doing this in sections, but actually this is all dovetailing in together. Nothing is a standalone in any of this work. This is all working together. So as a team, we updated our framework and looked at how that could work better. We then looked at the way that the units communicated with each other, how that communication was documented in each of those units, how teams within teams communicated with themselves so that the wider teams knew that there were families that were outlying families, because quite often the LNUs and SKUs fed back that they were unaware that antenatal transfers had happened and were not aware that these families actually existed and the babies had been delivered. So part of that work around helping support families was to work with VCreate to design the Moving Closer to Homes video, which is embedded, but I can see from the chat there's a few problems which we will iron out in the framework to help families at a very early stage in their stay in the tertiary centres understand what repatriation means and what that way may look like. And that was very much done in conjunction with our families, and they wrote the scripts for that video. So the families were very much at the heart of that, and it reflects what they felt families wanted. And just to share with you now, that has been adopted in Canada, so we're really excited. It's just been it's been adopted and adapted for the Canadian neonatal teams to use when their families move from their tertiary centres to their community centres. So it's gone worldwide. And we've also talked around the consistent updating and planning with families throughout their stays, and making sure that repatriation is mentioned from discharge. So we've worked with our neonatal units around the responsibilities of the NICs to ensure that those conversations are had with families from admission. And as Davy alluded to, that having those conversations throughout their stay with you, so that we do try to avoid that capacity lastminute.com transfer, which we know do happen. But if families are understanding of repatriation, and that is the aim, that all being well and their baby's progress continues, that we will be getting them back closer to home, even if that does happen sooner because of a capacity issue, it won't come as a total shock to families. And what we wanted to avoid was, one parent's feedback to me was, I didn't know my baby was going to be repatriated back to the local unit until I came to visit and found her in the transport incubator ready to go. That's an absolute never event, and must never be able to happen. So one of the feedback we're working with the LNUs and SKUs was around the difficult or inconsistent information giving from the NICs to the LNUs and SKUs. But I then turned that round to our LNUs and SKUs and said, well, what responsibility do you take for communicating with your outlying families? And they quite honestly said, none. We actually rely on information coming from the tertiary centres or the local units. So we set about thinking how we might manage that, and we came up with the link nurse role. So how we've established that is we've had a pilot running for the last 6 to 8 months between 2 of our tertiary centres and 3 of our LNUs and SKUs. And the role of the link nurse is that they are on the LNUs and SKUs, although I'll come back to the NICs in a moment. And the aim is that with the responsibility of the NIC is to ensure that the LNUs and SKUs are aware that they have local families with them within 24 to 48 hours of admission, so that the local neonatal units and SKUs are aware. Their link nurse will then contact the family to start to establish a relationship with them. Each of the tertiary centres have got packs of information about each of the link nurses and each of the units, which the tertiary centres are giving to the families within that sort of 48-hour period when the link nurse idea is introduced. And then once that link nurse has made contact with the family, they'll then establish how that looks from then on, and whether they communicate on a regular basis, whether that's a one-off. And it's entirely up to the family, and it's entirely up to the family whether they take on that offer of the link nurse or not. Some families may not want to engage with that, and families may engage at different stages throughout their stay. But what we have found is that in the pilot sites, it's worked incredibly well. The relationships between the local units and special cares have really been developed and very much appreciated by the families. And the link nurse has also been a conduit between all of the teams. And she's also been able to initiate those conversations around timely repatriation, about where the thoughts are with the tertiary centre, about when babies may well be ready for repatriation. They can also support those families to get them ready for the move back. They can answer any of those local questions that they may have about those units. They can organise virtual or actual tours. One of our link nurses, who is on the Isle of Wight, has actually come over to Portsmouth, which is one of the tertiary centres that's involved in the pilot site, and actually met a family before they went back to the island. So that was really, really good. And the families have found it so supportive, and really we have found that we've had less of those poor communications and fear and worry around families. So again, that trauma-informed care is so important, and that's something that the link nurse can deliver. So that's ongoing, and we're planning to roll that out as a network across the whole of the network next Monday, actually. So I've been working with some of the more local, the other tertiary centre that wasn't part of this pilot site, to make sure that they've got all that information about the link nurses. There aren't link nurses in all of our units at the moment, but they are kind of going to come on stream. So it's almost like, I don't understand the soft launch thing, but I guess it is a soft launch, but it's working really, really well. We, as care coordinators, are designing and delivering training packages for the NICs and for the LNUs and SKUs around this. And it's very much around that use of language from the NICs about the LNUs and SKUs, and it's about the promotion of care and the expertise that the LNUs and SKUs have, and the vital role that they play in the neonatal journey and the care of the family and the baby. So I put them in yellow because all of this is still ongoing and all areas are needing continual work. So I don't want you to think that, you know, we've absolutely cracked it, but we're certainly making really good progress and it's being very well received. And just onto the sort of final point about timely repatriation, and I know that has come up in all of the talks today. I think I've put the cogs in because that's definitely a reference in, and I know Shankar referenced that earlier on. That repatriation following that period of specialist care is a vital cog in the wheel of neonatal care, and ensuring that an ODN can work effectively and in a collaborative way. And also timely repatriation has several potential benefits. As Davy has spoken about, a decreased stress for family, earlier involvement of primary care providers and more efficient use of resources within the perinatal network. And also, you know, just referring to what Davy said, repatriation should be understood as a critical event for our families, and it is, you know, it's a significant source of distress. So if we can alleviate that distress by putting all of these measures in place to alleviate those uncertainties, by being able to answer the questions, building confidence and trust and building relationships between our units, then I think, you know, repatriation of families should be more seamless. And just to sort of complete, timely repatriation is still an issue across Thames Valley and Wessex, and it's still something that we need to work on a lot more. But I think we're very much in the neonatal world around making sure that babies are born in the right place and have the right care at the right time. But it's equally as important to make sure that a baby provides the right, is in the right, has the right care and is in the right place and at the right time when it comes to repatriation. And when it is safe to do so, the right care for a baby is on a unit closer to home. And I think preparation includes open and honest discussions with families. That's me.
Thank you, Lisa and Louise. That was really informative and useful. So now it's the Q&A session. So thanks to all the fellow speakers for their excellent presentations. Now we'll open the floor for questions. While people are warming up to put their hands up and ask the question, I'll just go through the chat. I think there's some interesting comments in the chat about, you know, how difficult this can be, particularly when the, you know, infants are sort of across the network boundaries and etc. So again, you know, we have numerous things in the framework about, you know, where the responsibility lies in terms of repatriating that infant. And usually it will be within the home network where the booking hospital is. And I'm really sorry about, I think there was a technical glitch with one of the QR codes, and I think it seemed like we were providing some free advertisement for hotels.com, but Laura, our communications officer, has very efficiently removed that problem now, and the framework is back online and the QR codes are working. I just checked them out. And there's some very useful comments about resources that are already being developed. Well, already or there or being developed about the video virtual tours of the units. I think this is something audience can, you know, learn from each other and replicate it, you know, for their own patches. So any questions? So stun them all to silence.
Yeah, we've obviously done such a good job. I note in the chat, Sankara, that Naz had asked about the link nurse roles, whether they were ODN or unit level, and they are unit level roles that we have talked about, so that actually that real communication between units is kept up.
So there is a question. Julia Arthur, please.
Hi, yeah, I was just wondering, so we in our level 3, sometimes we come across parents who have had like a difficult experience, or not necessarily on the neonatal unit, maybe the maternity, or even like family members in that hospital, and they don't want to go back for that reason. How would you approach that?
So shall I, well, I think I'm going to, shall I start and then bring Davy in?
Yeah.
That's probably, so I think from an ODN point of view, Julia, I think absolutely I'd go back to Davy's rope trip, which I was very impressed with, in which I would say that there's a real need here to go back to them and have a conversation about the whys, because sometimes that's because, you know, grandma had something that, you know, that didn't quite work out and it's not really a maternity issue, and maybe arranging a visit to that unit or a member of staff to talk to them from that unit is enough to help with that. Or I think sometimes there is definitely an offer of moving somewhere else, but I think that has to be really carefully thought out, because my experience is that happens sometimes. They move to another unit and then that other unit starts talking to them about repatriating them back to the original unit that they didn't want to go to. So I do think there is something about that communication. And I think if you reach a real impasse, there has to be some really, you know, carefully thought out conversations, which I don't think can be a one size fits all, or would certainly be my viewpoint. So I think sometimes, you know, there's going to have to be a really difficult conversation that says we need to repatriate you for some reason that's out of everyone's control. And there may be times where a decision is made that family should not be repatriated to the local unit. And I think that really does have to be a sort of individual conversation depending on the whys and wherefores of it. And it was one of the things that I think in the framework is really difficult to pin down because it is so grey. I don't know, Davy, if you've got any thoughts on that one.
Yeah, I'd agree with everything you just said there, Louise. I think, Julia, I thought the words in your question were really specifically quite interesting about like a difficult experience. I think understanding the nature of that difficult experience is the kind of crucial point here, because it may be that there have been difficult experiences of care, and it may be that the family feel like their relationship with the team there has been ruptured, that they have struggled to establish trust with that team, or it may be that there has been an incredibly traumatic incident, and being back in that environment is going to be a significant trigger for flashbacks, reliving experiences, which so there's a whole kind of raft of different reasons why that might feel difficult for a family. And I think exactly what Louise said, that it just needs to be considered with the family as to kind of what is the concern, what is the struggle, having that really clear message that we don't repatriate for any old reason. We repatriate because actually it's in the interest of your infant to receive the care they need in the right place at the right time. If that's going to feel difficult, what support are you going to need for us? What support do you need to make that feel like it's going to be okay? And yes, there may be situations where that repatriation feels unsafe, psychologically unsafe, puts people at risk of significant relapses into post-traumatic stress disorder. I think it just needs to be taken on an individual case-by-case basis. But yeah, in my experience, actually, it does come back to the kind of the conflict and the escalation that actually, for many families, if you start off with that message that you need to move, whether you like it or not, then you're setting up an escalation which will be very difficult to come back from. If you start off by aligning yourself with that family's experience, really understanding the nature of the struggle and the difficulty, that there are often ways to make that feel like it's okay, or ways to help that family develop felt sense of safety in an environment where perhaps it's not felt present before. And if it is more about ruptures, I think more often it's less about specific traumatic incidents and it's more about a rupture in the trust in the relationship with that team. Then actually avoiding the repair of that rupture is not a helpful thing to do. We need to try and repair those relationships, because the chances are that that's going to be the team who are providing the developmental follow-up for 2-4 years time. So I think actually sometimes it is about as Louise said, approaching those difficult conversations and thinking what is needed here to re-establish the trust in this relationship. How can we use the resources that we have available to us to re-establish that connection and the trust?
I think as well, can I just jump in, Louise, is just as well from what Davy was saying. I think that's why we're hoping with our link nurse role that hopefully those relationships can start to develop much earlier on. So some of those families will not have been uplifted, they will have been transferred antenatally, so the teams won't have ever have met them. But sometimes there's that sort of thing around, well, the NICUs are the best team, so they can support and they can care for our babies so much better. But I think it's actually around how we, like you say, how we discuss our LNUs and SKUs and the excellent provision of care that they can give. And if that relationship is built early on with that neonatal unit, then hopefully we can just, help support those families through that day because of that built relationship before they go back.
Thank you. We've got a couple more questions. I think next is Alison Bedford-Russell. Alison?
Yeah. No, I'm
Oh,
trying
hi.
to. No, I unmuted myself and then accidentally muted myself again. Hi, everybody. I think the repatriation document is decades overdue and summarises. It's kind of disappointing in a way that for a lot of what's common sense and isn't new, it's taken an incredible amount of work by all of you involved in fashioning this document to lay down very clearly what is almost common sense, but has vexed the repatriations for many years. One of the things within it, and I like the job description for the for there to be a designated nurse who is managing this sort of thing. One of the things that perhaps Louise might be able to answer is and it may be something now that this document is out live, is what resource is made available to appoint such individuals within neonatal units. Because honestly, decades, we've realised that this sort of patient flow requires active management. But when I really enjoyed your presentation, Davy. I don't think we've met before, because I think you summarised very nicely what happens sometimes when you get the narrative wrong from the start. You can build up that relationship. You can talk about right place, right in that right place, right time, etc. And we've done that for years, and it only takes someone going, bad news, we've got to move your baby because we need the cot, and that just chops everybody's legs off, including you as the consultant looking after the child. It's just such a destructive way to manage it. And of course, you speak to parents. I've got parents who still contact me 30 years, 40 years after I first looked after their children. And they are very traumatized by that happening. But it's the resource, my big question. So I really congratulate you. I think this is a great document. And I like the fact that you've put in that surgical babies really need prioritising. Thank you for that, or I was late to comment. Because it's really important to preserve the very precious surgical cots that we have. But where's the resource? And is that one of the next steps? Because I don't think that was in the neonatal GIRFT to make sure that there's someone designated to look after this sort of thing, which I think commissioners might regard as soft, but actually has a very big impact, both acutely on the teams as well. It's really traumatizing for the teams when you're dealing with parents who are traumatized because you've got to repatriate and you're like a blue whatnot fly whizzing around trying to sort the baby out, and then you've got weeping parents and nursing staff who are, everybody's discombobulated. So is that one of the next steps, is to get the resource so that we get in a staffing document you know, commissioners need to commission these appointments?
So I would absolutely, Alison, I echo what you're saying. I think it's really difficult. It's traumatic for everybody. And I would say these roles definitely help. And I would like to promise you that there would be some resource anytime soon. What I would say to you is, bear in mind, we're still looking for the resource for some of those quality roles that were in the toolkit in 2009. So I do think there's a level here that we've got to think that this, in the short term, potentially needs to be some real thought out planning around people's workforce and how they use them, etc. I absolutely take that that's not always possible, depending on what your workforce is like. However, what I would say is that there is now a recognition that roles such as these, the quality roles from nursing, actually it has been an oversight not to quantify them and get them into commissioned staffing models. So there is concerted work going on to look what these would look like. And within that is spy care, is family care at a unit level. So although not currently badged as this sort of role, that we are definitely at a place where we can look at this role and build it into those other roles. So although I'd like to promise you something soon, I don't think something will come soon, but it's definitely there in the conversation.
Thank you. And again, you know, some resonating conversations in the chat as well about the importance of repatriation link nurse role, so which is sort of really good to see. Moving on to the next, I know it's 3:30, but I think we've got time probably for 2 or 3 more questions. Ahmed from Sandwell.
Yes, hi. Using Alison's phrase about wrong narrative from the beginning, the phrase closer to home is non-starter in very condensed, compact networks where the local neonatal unit and the NICU are equally distant from the family homes. So how would you sell it then if that factor is not there at all? In fact, the NICU might be closer to them than the actual unit they were booked in. This is for number one. And then number 2 for Katy, you mentioned something about how you felt about being received at the local neonatal unit, and it was a little bit shocking and doing a lot of tests and things like that. What do you think could have been done differently to make your experience better? Thank you.
Shall I go with the first bit? Yeah. So thank you for that. So I would say to you, I think this is a problem. It's something we discussed a lot around that term care closer to home. I think it's a universally used term across the NHS, and not just for neonates, but for, you know, all levels of care. So it is problematic. I completely hear where you're coming from when units are close together. I think in terms of the framework, it's a way of expressing that we have to, you know, we have to proportion somehow the activity in order to keep pathways flowing. And I think it comes back again to this trauma-informed approach, making sure we're having early conversation with families and explaining neonatal care to them. I think we are occasionally still very paternalistic, and we do not explain very early on to families some of the things. Now, I think there's definitely a balance. We should not be saying to families, you know, in order to keep the health service going, we need to move your baby over here. That's, you know, I'm absolutely not suggesting that. But I think Davy summed it up really nicely when he talked about that, you know, right baby, right place. I think one of the things that we have done very badly in the past is that we do not big up our colleagues in other units, and occasionally do quite the opposite. So I think, you know, if what we're having conversations in the NICU around how our LNUs are, you know, a much better place for them, you know, in terms of that next step, that we will make sure that you know, that therefore there might be better facilities in some. Now, I think our problem always comes back to that is not always the case. So, you know, we've alluded to there not being AHP services. There's sometimes not parents' bedrooms. And I do think this is something we really need to be mindful of in a network, that we make sure that when we are talking to parents, we're not promising them something that's not true, but we are also making sure that we are, as a network, working to make sure that what is true is that when they go to a local neonatal unit closer to home, that is all about going home, that there is good preparation, that they are getting there perhaps a different level of caring of their baby than they would have got in the NICU. So I absolutely agree it's problematic, and I think it is down to language, that we need to be really careful about how we translate that. And I know I've not really answered your question there, because I don't think there is one, but I think we just need to be careful that we don't use it as a you're going because it's closer to home. It's a way of quantifying pathways rather than anything else. And then Katy, I don't know whether you've got anything to bring around that when you arrived. Sorry, David, did you want to come in on? Sorry, Katy, did you want to mention? David, did you want to?
Yeah, I wonder if just helpful for me to. I was just thinking what you were just saying there, Louise, about not kind of going into great depths with families about the kind of the systemic pressures on the NHS and all those things. I also think it's okay to talk with families about the fact that there are other reasons why we move babies. I think avoiding those conversations ignores the fact that actually that is a real factor in some parts of the repatriation process. I think when it becomes difficult is when you as a healthcare professional are facing a family whose baby is about to move, and it's about your baby right then. And it feels very personal. It feels like it undermines the relationship that you've built with that team. But actually, if you start that conversation right at the beginning to say, sometimes we move babies, or I guess maybe it's about thinking about, your baby required an intensive care cot for this reason, because of their medical needs at that time. When they no longer need a cot in this intensive care unit, we will be thinking about a more appropriate location. Now, in some areas of the country, that might mean that it's closer to home, but actually it doesn't necessarily mean that it's closer to home. It's part of this kind of real tricky thing about explaining the nature of networked care. But it's a real thing, and I think we shouldn't avoid having those conversations with families. But I think if we do it in the heat of the moment, as a psychologist, one of my mantras is strike when the iron is cold. You should never have these difficult conversations. Or if you've got a choice, you should never have these difficult conversations when emotions are heightened. If you can approach it at a time where the decision is not immediate, that's always preferable. So I think starting this again comes back to starting those conversations early and repeatedly coming back to them to make sure that you and the family are on the same page. I think that's really important.
Thank you, Davy. Katy, you wanted to say something? Or
yeah, I guess just answering the question about the initial days and how that could be easier. I think so. There's two elements here. One of them was Jessica was sort of put in an isolation room, as I think all babies are, as a new arrival, and tested for things like COVID, MRSA, etc. So I'm no expert, but I think that's standard procedure. I guess for us, we weren't warned about that beforehand. And I would question, was that truly necessary, given she was regularly tested for all that back at the initial hospital, and was in a tank a lot of the time, an incubator, sorry. So that's one element to it. The other element, from our perspective, going from level 3 to level 2, it speaks volumes about the nature of the professionals that we dealt with, in terms of, from a medical care perspective, it was excellent at both. We noticed no difference, and we didn't think to be concerned about that at the time, and there was no need to be. Maybe that differs to other parents, but for us, that was fine. On arrival to the level 2 unit, it was more the wider piece about how it felt, and the luxury of space at the level 3 unit, how quiet it was, and just maybe a plea to, you know, treat parents with, when they're arriving at the destination, with absolute kid gloves. They are scared, they are tired, they are at the end of their tether, they are worried. So there's the information stuff in terms of you're at your maximum capacity to absorb, but also it was just things like, you know, at the level 3 unit, we were allowed to eat at Jessica's bedside. At the level 2, we weren't. We didn't want to leave her bedside, so we didn't eat for something like 8 hours, and we were exhausted, and you know, little things like that. Just, you know, I was told off for wearing my coat within about 5 minutes of arriving, and I didn't know that was a thing. I didn't know the procedure. So again, it's just that kind of kid glove kind of, you know, I was very sensitive because I was very upset and emotional. That's a procedural thing that I would have absolutely said, you know, I'm ever so sorry, I didn't realise that, etc. And the timing of, you know, within 5 minutes of arriving, just little things like that, which I think cost no money, and they're not medical things. It's the wider atmospherics that would help.
Absolutely, I agree. You know, I think these procedures and things are always going to be different in different places, but it's about how you communicate it. And as you say, you know, treat them with, you know, kids' gloves when they come. I think that's absolutely important. You know, huge, you know, learning for all of us. Thank you. I think we got 2 more people, the hands up. I'll go to Fiona Metcalf, please.
Hi there. Thank you for all your talks. They've been fantastic. I was involved in some parts of this project and gave my kind of take on the kind of surgical side of repatriation. And within my role, I'm a lead nurse for neonatal surgery in Leeds. And I got a kind of unique role where I can go out to the DGHs to help support the repatriation of surgical neonates. And that's been a real positive for families in building that confidence within the parents, but also building confidence within the local teams, and providing kind of, you know, that education and that support and that person, that go-to person to kind of go through some of those kind of natural questions, and just to have that phone call after repatriation. Did you get all the information you needed? Do we need to provide you any more from the tertiary centre? What was your feedback on that experience of the transfer, and, you know, what information could we provide? And then we can kind of develop kind of care packages around families that are bespoke to the families or bespoke to certain conditions. And we've got certain conditions, you know, certain families, you know, where we can send them back that don't have, you know, very high level care needs, but they still have an underlying, you know, condition that may seem very complex to a DGH, to a local hospital, but actually that they're, with education and training and looking at that, they can absolutely provide that support local to home. And I think I totally agree with the comments that Alison has made around workforce, and what Louise, what you've made around, you know, really managing expectations. But I would just add in as well around those education strategies, because I know some successful repatriations that I've been able to manage to influence pathways on was really influenced by some education plans. And has resulted in me not having as much input with some of the DGHs now because of that embedded education program. So it was just to kind of add that really as something that that we've done.
Thank you, Fiona. I think move on to the last question, which is Richa Gupta. Thank you.
Louise will know me. I'm one of the neonatal team up in the northwest. Thank you very much for all this amazing work. As Alison Bedford Russell said earlier, it all seems like common sense, but actually when you've put in the detail, the rationale, and from the parents' perspective especially, the reasoning for supporting people to get back to the right place is important for everybody to understand. And in terms of geography, as has been mentioned, you can have units that are quite close to each other geographically, but when it comes to babies and families' onward journey beyond neonatal units, it is really quite important that they are in the right place. And sometimes our conversations with parents who, let's face it, families get attached to wherever they kind of are and looked after intensively, regardless of that location. And it's heartbreaking for them to have to move on into the next stage. But when it is explained to them that actually their baby's not going to be in hospital forever, they are going to be going back out into the community, and it's important that the paediatricians and the local, whether it's allied healthcare professionals or the community sort of professionals in that area, get familiar with them, as they need to get familiar as well with what's on offer for that stage of their baby's journey. And when it's done at a time, the transfer is usually arranged at a time when a baby's safe to be cared for in that different location. Sometimes parents understanding that rationale in the biggest sort of scheme of things helps them to understand that building a relationship with that local team is really important. And we've kind of sort of had a few bridging kind of steps, especially to facilitate parents who want to perhaps have their follow-up in, you know, with us or in a different place, and with outreach and things like that, where we can have virtual meetings with people and communication going, especially with complex babies, where parents kind of feel, well, how are we sure that everybody's going to know our story up till now? And I think it's giving them that assurance that actually we do share information, and it's important for them onwards to be in the right place, so that the next lot of the next team that's going to be assessing them and trying to make sure that they're providing their needs for the future are aware of what those are. So it is about framing things, and it is most definitely about making sure that parents have assurance that wherever they are in the service, they are going to get the right care.
Thank you. I think totally agree with what you said there. So there's no more questions on the chat. I mean, questions, hands up, but there are some interesting comments on the chat. I'm sure, you know, people would have already read. So it's about actually having that conversation from level 3, you know, about the repatriation as a supportive conversation, saying that your baby is getting better, is going to a unit where it can be appropriately and safely managed, and having the conversation as a supportive, rather than framing that as a downgrading care thing, you know, which could also, you know, give a different impression to the families. I think it's really important. Okay, I think we have to nearly there. I think we're going to bring this to a close. So thank you very much for my co-speakers for your time today. The sessions were excellent, and we had really good discussion amongst the wider audience as well. And so thank you very much. And last but not the least, you know, Kate and Marcus and Laura in the BAPM office, you know, without them, we would not be able to get this framework out there. So, you know, a round of applause to them. So thank you so much. So enjoy the rest of your afternoon.